And it's so nice for everybody to come together. And with that being said, we will get started. The link is still available. Please share with your friends to join us tonight so we can all come together and talk about the PBCs. So welcome to our session, everybody. My name is Dr. Farah. For those of you who don't know me, I've been doing PBC prep for 10 years. I've done continuing education training as well. I started my journey at Pharmachieve, and then I did continuing education with the college, and then I branched out and been collaborating with many other people. And I'm one of the faculty members and partners with SolRx, where we have a really dedicated team here we all have the same goal, which is to support you in your PBCs. And you'll be talking to our wonderful team. But I will be starting today. I think and make sure you guys all participate, as you know me. I love it when you talk and participate because we're in this together. I think one of the difficult things for me over the years is when students attempt the exam and don't have proper guidance and don't have proper support because you are all trying to settle in Canada, you're trying to bring your families here, you have a lot riding on these exams, and you just need proper guidance, proper support. And that's what we're about. That's what I'm all about. So I'm so grateful that you guys are here so that we can spread the word to support you. At the end of the day, that's all we want to do. And we'll talk about misconceptions because the MCQ is different from EE. And we'll talk a little bit about that, but you'll see it is different. The scoring is different. The mentality is different. And a textbook can't teach you everything. So one of the hardest things I hear a student say sometimes is, Dr. Farah, I just attempted and I took listened to some lectures, and I did mostly questions and past papers, and I didn't pass. And now I'm on my last attempt, and I'm desperate. I need to pass. And we just don't want that to happen to you. We want you to be able to pass on your first or second attempt because you also then save time, because the longer you prolong it, the longer it takes to become a licensed pharmacist. So with that being said, we'll get started, and please ask questions and participate because we are here. This is for you. This is for you and for us to support you. And so we can meet our team. And Dr. Parmeet, if you can do the introduction to the team, that would be wonderful.
Awesome. Thank you, Dr. Farah. So it's a pleasure meeting everyone here today. I do see some familiar names from OSCEs, which is always nice to see. But as Dr. Farah mentioned, my name is Parmeet. I'm one of the directors here at SolRx. And, I've been part of SolRx for many, many years now. When I graduated pharmacy school, I did become a manager at Shoppers Drug Mart right away in terms of an experience. I also worked at Sick Kids Hospital for quite a few years doing some clinical research on pediatric cancer medication. And currently, I am full-time pretty much working away with SolRx and mainly instructing the OSCE as well as the MCQ course, along with our other programs such as Red Cross, which we are running, hoping to launch hopefully next month. And that's a little bit about myself. I'm just going to hand it over to Aarav, and he's going to give a little bit of insight of his experience. And Aarav, the floor is yours.
Sure. Thanks, Parmeet, and welcome everyone. Thank you so much for joining. So my name's Aarav, one of the directors here at SolRx, and I've been teaching management in the SolRx MCQ component for many, many years now. I graduated at the same time as my colleague Parag here from UFT, and we were actually one of the first to start the management MCQs, and then we branched into therapeutics, joining hands with Dr. Farah. And I have my own independent pharmacies as well, so I'm an owner and have extensive experience with management, which I'd like to share with all of you. So welcome, and we really look forward to sharing our experience with all of you. I'll pass it along to my colleague Parag now.
Thanks, Aarav. Hello, everyone. My name is Parag, and I am a UFT graduate and a community pharmacist. I actually say that with pride. I love community practice, and so much so that I run and operate an independent practice right now, currently. And I'm actually one of the initial course developers with SolRx, the pioneer, I would say, for the management portion. So that's a little bit of a history tidbit, but we're super excited for this new evolved and revamped program, and happy to be here. Pass it on to Parmeet now.
Yeah, and I just want to quickly point out that you might see two faces on the screen that are not here today, which is Vipul Shah, who is the SolRx founder. Primarily, he runs both programs, OSCE and MCQ, but today he's not in the meeting here, but I just wanted to give him a quick shout out. And also Dr. Hye-Yeong, you can see at the bottom right corner, she is our calculation specialist. So if you do enroll in our course, you will have a lot of hands-on practice with Dr. Hye-Yeong to learn a little bit about calculations and how to handle calculation and tackle calculation questions on the exam. Because as you know, that is one thing many people do worry about. But she has developed a lot of skills and a lot of tips and tricks that she will share with you. And that is just a little bit about her. So I'll hand it over back to Farah, and she can take the meeting a bit further.
Ooh, no, thank you. And I hope you guys enjoyed meeting our team. And please make sure to participate. And there's a great question online about EE and the difference between EE and MCQ, which we will touch on very, very shortly. So keep asking your questions, which is awesome. So first things first is let's talk about the exam, the MCQ qualifying exam. So this is a written exam. It is about they give you 4.5 hours, but half an hour is dedicated towards doing the post-exam survey. It is intensive. You have about, and you will see, you have about 200 questions in total, okay? And the thing with this exam is 50 of those questions are pre-test questions. And we'll talk about what that means, but it's super important for you to understand because that is why MCQ is so different from EE. So in MCQ, you have 200 questions. And out of those 200 questions, 150 count. You can see they count. And then 50 are pre-test. And what that means is they don't count. And this is what is super frustrating for everybody on this exam because they don't tell you which 50 questions don't count. And because they don't tell you, you are attempting every single question as if it counts towards your score and spending time. And so that gives you about maybe a bit over a minute a question safely. So you have about a little bit over a minute to attempt each question. In EE is totally different. In EE, there's no pre-test, so every question counts towards your score. And in EE, you have to get a 60% to pass. No questions asked, just 60%. But they grade MCQ very, very differently. And we'll talk more about that. So the PowerPoint will be available for everybody later. And everything I'm saying is just written over here for those who like to read. But what it says is the 50 questions that are pre-test don't count. And how do they determine which questions are pre-test? So these questions allow the PEBC to evaluate future questions. They want to see how people do on certain questions. Based on my 10 years of experience, I mean, nobody knows for sure, but based on my experience, I find that questions that are really out there, questions that are maybe second or third line, or questions that are not an entry to practice requirement for a pharmacist, those are usually the pre-test questions. But when you're faced with a very, very complex question, it'll throw you off and then affects your ability to focus on other questions. And that can get a little bit challenging. So we try to help you and guide you to focus on what is likely an actual question that counts versus a pre-test question. And the thing is, with this exam, everybody knows is there's so much material, and it's about studying smart. And it is impossible to know everything. You have to have proper guidance, proper support. But anyways, that answers what pre-test questions are. Does everybody understand what a pre-test question is? Because I get this question all the time, and I want to make sure you understand it. And is there anybody that doesn't understand? Because if you don't know, I want you to tell me so I can make sure we're all on the same page. So it's 50 questions that don't count. We don't know which ones they are. They're usually the bizarre questions, the super out there questions. Okay, and evaluating exam does not have it. Another difference between the MCQ written exam and the evaluating exam, the evaluating exam has a syllabus. I still remember it was like a, 80-page syllabus. It had clinical topics, management, and it had pharmacology and all of these things. And yes, there are changes that have come to evaluating exam, but over the years, it had many non-clinical physiology, pharmacology, medicinal chemistry, biostatistics, biochem, etc. concepts involved. The purpose of the evaluating exam is to assess your baseline knowledge. So it's basically all of pharmacy school or undergraduate studies in one exam. And that's why you have many different topics. And then hello to those joining. And then MCQ takes it a bit further, where you have case-based and more concepts, heavier in management, more gray areas where there's no black and white answer. It's more about you having to figure it out per se. And absolutely, we will be sending this session out, absolutely. And here's the thing, you'll hear things where they'll say, okay, well, MCQ is one step up, evaluating exam is very baseline knowledge. Over the years, students will tell me, Farah, EE now has case-based questions. It has more complex cases like MCQ. So that is also true as well. So what I would like to say is that MCQ is similar to EE in management and clinical, and there is overlap. However, in MCQ, they do take it a step forward. Evaluating exam has its own syllabus. MCQ is based on the NAPRA competency. So the National Association of Pharmacy Regulatory Authorities, known as NAPRA, has specific 9 competencies which are tested on both written MCQ and OSCE. So these are the 9, and each question is categorized under each one. Okay, so it's not really a syllabus, but these are the 9 competencies. Now, how is the MCQ graded? And guys, if I'm going too fast and you want me to repeat anything, please participate, okay? And if you understand what I'm saying, at least give me like a smiley face or like a thumbs up or something so I know you're with me, okay? So going into the grading of MCQ, yay, okay, thank you for the smiley face, I love it, thank you. Good, we have to participate, I love it, good. So, because, I can't see your face. I don't know if you guys are like smiling or not. So I'm just hoping. So that's wonderful. Very good. So the MCQ exam is graded in a super complex way. They call it the criterion reference scoring system. Totally different from EE. EE is 60%. That's it. And wonderful, Anam, no problem. So EE is 60%. Here it's a bit more bizarre. So let's go one by one from the top. So they look at 4 main different things. The first is raw scores versus scaled scores. As we all know, there's many different versions of the MCQ exam. The person sitting beside you, if you are in a test center, will have a totally different version of the exam. So once you complete your exam, you could get 70%, 80%. So they'll take that raw score and they will then say, okay, well, this question may be more challenging compared to the person B. They may have had an easier question. So they will then look at each question and look at how difficult or easy it is. And then that'll allow the PBC to say, okay, well, this question is weighted more. This question is weighted less. And that works to your advantage. So this is how I think about it. Because they score it this way, if you were doing a question on the exam and you're like, okay, this is crazy hard. This doesn't make sense for a pharmacist to have to know. It could go one of two ways. One way is probably a pretest. If it's not a pretest, and if you found it super hard, chances are everybody found it super hard. And guess what? It's weighted less. And this is why I always tell students, always do the easy questions first. I will never forget when I went in, and I have students, you guys who know me, I've said the story multiple times. When I went into my exam, I looked at it, I'm like, I don't know what this is. I flipped. I don't know what this is. I'm like, I don't, and I was on the computerized exam, but I didn't know anything. I'm like, I was stuck. I was foggy and I didn't know what to do and I was panicking. So what I did was I said, you know what? I'm going to work backwards. So I went to the last question and I said, let me find something I know. And that's how I started my exam. I said, okay, looks like I know this question, let's attempt it. Because you only get like a minute and a half a question. And if a question is easier, chances are everybody will be able to attempt that. And then I worked towards it, and guess what? I got to the harder questions in the end, and some obviously I was like, this doesn't make sense, but the harder questions I was able to attempt because the blood was flowing in my mind and I was able to get to that. Okay. And because the grading is this way, that's the mindset you go in. And the problem is we're human, right? So if we see a difficult question, we'll stop, we'll think about it, we'll analyze and panic. But that's not what you do. Okay. And then the PBC also does this fancy statistical equating process, they call it. They look at, again, questions on all the different versions and assess for fairness. If one is harder, one is easier, the weighting changes. And so they do an assessment. Okay. You do not need to understand how the grading is. But what I need you to understand is that it's not point blank pass or fail. Okay. So EE is 60%, MCQ, it's variable. Okay. Are second and third line important from MCQ? So here's the thing. If you do a question with me today, and if you do that same question on your exam, I can almost guarantee in an exam setting, that question will be 10 times harder. You will be saying, this question is extremely hard. I've never done this before, and you will find it much harder than if you do it outside of the exam. You will also have something called recall bias. So I'll call students, they'll tell me, I got, I don't know, 50 calculation questions. I got this. And then when I say, okay, let's break it down and go through it and dissect it further, I realize that when they're in that exam mindset and they're stressing, they may misinterpret a question. I've seen people think a question is testing on management when it's testing on clinical. I've seen people believe a question is about dosing, where the question is not meant to be testing the dose, it's testing for other things, but we get so confused and sidetracked. So these are all skills you have to develop. So if you talk to your friends or you talk to other people or read online about the questions or past papers, half the time I see the options wrong when people say, I swear this came up on my exam, because of recall bias. So what it comes down to is experience. So having done this for so many years, I kind of have an idea of what could come up and how to prepare. And not just me, our team does, we as a company. Second and third line drugs, are they important for MCQ? Not significantly, but if there are allergies to first line medication, then second line can come into play. Sometimes a question will look like they're testing on second and third line medication, but it would just be a clear allergy to all first line options. And if you rule out the allergy, then you're left with a second line drug. So students believe they have to memorize second line and third line and all of these things. But if they're training their minds in the right way and they're able to rule out certain things, they're able to come to the right answer. Does that make sense or no? If not, tell me. But what I'm trying to say is, let's say you're looking at a question and you memorize for depression first line treatment, okay? And then you look at all the options and you're like, I don't understand. Maybe the patient will have an allergy or something to some of the medications, and then you'll be able to rule out majority and then be stuck with a potential second line. But that doesn't mean you're being tested on second line directly. But students will say, no, we're being tested on second line. So that it's a mindset shift. Also, whenever you take a course or if you get proper training, we can only teach you key things. Like I will never sit here and walk you through line by line by line. I will share with you tidbits, but you also have to do the homework. So people will expect if they attend a class that they'll know everything. But you have to do the homework, follow through, attend. You have to do the work yourself too, right? I still remember I was in high school and I went for my first class of math tutoring, and my parents dropped me off. And the person signing me in, and she looked at my mom, and my mom was like, you know, it's such a relief. Now my daughter will do well in math. And then the lady at the reception says, well, just because your daughter comes to class doesn't mean she'll do well. She has to do the work and she has to do the homework, right? Just because you attend something doesn't mean you're going to succeed. And so when I remember that, I was like, yeah, it's true. And then I did my math homework, which helped me. But you see what I'm trying to say? And let me look at your comments. Okay, let's take a look here. Penicillin allergy, exactly. When somebody has a penicillin allergy, we're ruling out a lot of things, exactly. Two-liner, one-liner. So here's the thing. You cannot predict how many case-based questions you will get. I've seen people get 10, 20. I've seen people get 5. I've seen people get one case linked to 5 questions, 10 questions. So you have to be prepared for it all. And a lot of the times, the cases are actually there to like confuse you a little bit, because you'll look at the case and you'll say, oh my gosh, there's all this material, but you won't need most of it. You'll just need maybe the last line. So we will practice with you and show you those things. Sometimes I'll find that case-based questions easier than non-case-based. It's intimidating when you look at like a heavy case, right? So we teach you, and if you get a proper training, you will learn not to get intimidated by those things and look for important things, because you don't know what you will get. You cannot predict. So it's all about having the right training. And absolutely, Rajvi, no problem. And you've heard from some students that PBC sets a fixed number of students they want to pass. So that is not true. So there's so many rumors about all of these things, but that is definitely not true, okay? Unlike EE, is MCQ same for everybody? No, it's not. Do we need to study doses? You do for some things. Some things you don't, but for some things you do. So it's not very black and white, and it's topic-based, concept-based. And sometimes if you don't know the doses, you are able to figure it out based on other factors on the exam. But we will guide you as to what to know. Perfect. And when it comes to how to start studying, so here's the thing, everybody is so different, Okay, I typically recommend taking a structured course that provides you with the syllabus and material to focus on, because with appropriate guidance, you are able to succeed. But I do not recommend, and you will see that. Let's go to the next slide and you will see what I mean. Is a question bank and past questions enough, or is formal training required? You need formal training. You need formal training. When you are attempting questions, a lot of it is gray area. It's not as black and white. Okay. Memorizing will not be enough to succeed on this exam. You may be able to get away with it in evaluating exam to an extent, but not for MCQ. On our team, each member is a pharmacist. You have multiple pharmacy owners. So when it comes to management, which is 50% of your exam, and our team will go into it in more detail, you have pharmacy owners and extremely experienced pharmacists teaching you management. Because when they ask you questions on your exam that require critical thinking, the only way you will be able to attempt those is if you have been taught by somebody who guides you and says, okay, if you are faced with this, approach it this way, approach it that way, rule this out, rule that out. You cannot get trapped with old questions because there's so many versions of the exam. This is an entry to practice exam, so it's what a pharmacist should know. And yes, it is true that sometimes you will see so many questions that will throw you off. Remember, how many questions is 50%? 50 questions. 50 questions out of 200 questions is 25%. So imagine 25% of your exam doesn't count. So it is likely that 25% of those questions are super bizarre and super out there, and you may mistake them for things that count, and that can then throw you off in the future. Is 50% of the exam management? Yes, so we refer to management as all non-clinical. So 50% is management, 50% is clinical. So when you get proper training, the courses you take, 50% should be allocated to clinical, 50% should be allocated to management. It shouldn't be one or the other. It should be both in a structured fashion. So that's very important. And a lot of people don't know that. Cases are usually not included in pre-test. They can be. They can be. They can. But it depends. And we, again, never know. It's just based on all of our SolRx's, our years of experience, we can kind of gauge, right? It's all about training yourself to wear a pharmacist hat. Some MC courses, Marcus, focus on guidelines and some on CPS. I know, because I've been at this for so long, I know. And this is the honest truth after doing this for so many years. So I'm going to give you the honest, raw truth. When I first started out, okay? And this is honestly, I had reached out to PBC. Is it guideline based, this exam, or is it based on CPS? How is it differentiated? Because there are discrepancies between CPS and the clinical practice guidelines. There are discrepancies because sometimes the CPS takes a while to refresh. Like they may do an update for a topic after a year or after 2 years, whereas a guideline could have came out yesterday. Also, it is true that CPS has authors. So when you have authors, what happens? You have opinions. And so I spoke with PBC years ago, and I brought this and I said, okay, I've noticed discrepancies between guidelines and CPS. They said guidelines, like they didn't explicitly verbatim say, but they said, of course, guidelines would be the ultimate source. The ultimate source is the guideline, right? Because in case the PBC takes a while to, CPS takes a while to refresh and update. But what I found, and that's true, that statement is true, that the ultimate source is a guideline. That's where the evidence is. And CPS is based on that. However, in all my years, whenever there's a discrepancy between CPS and guidelines, the CPS has been tested. And if it's a significant discrepancy, it doesn't appear on the exam. Do you understand what I mean? Because that's really important. And that's something I've learned that, does that make sense, guys? If it's a significant, okay. Guidelines are the ultimate because that's where the evidence comes from. CPS is based on guidelines. But when there are discrepancies, meaning if there's differences between guidelines and CPS, which I've seen over the years, I've seen so many. If it's a really big difference, I haven't seen it come up on the exam. And if I have seen a difference come up, it's been based on CPS. So you don't need to go to the guidelines for your exam based on our experience. The knowledge, the information. So here's the thing, the information in CPS is enough. The information in CPS is enough. But reading that CPS is not enough. Because a lot of students will buy CPS and read it. But guys, this is an application exam, not just a reading exam. So what you do with that CPS material is important. Interpreting it. Like, for those of you who know me, I'll take that material, dissect it, and help you digest it for the exam. Because that CPS is not just for MCQ PBCs, right? Pharmacists use it in practice too. So it's not just about reading that book, it's about taking it, dissecting it, and modifying it in a way that helps you on your exam. Does that make sense? And again, this is after 10 years, okay? We have all been at this for so many years. And I've like been on the fence about it because you see different things, you hear different things. And again, what is likely to be tested is what you have to focus on. Are you going to sit and memorize infectious disease first, second, third, fourth line? And it doesn't make sense. And I feel like we would be doing you a disservice by saying, look, here's all the information, learn it all. Is that right? I wouldn't be able to sleep at night if I did that. Because there's no way any human can know everything. We have to help in the best way possible. And I hope I'm not like repeating myself. I just really want to clarify the message because there's so many misconceptions out there and it's like heartbreaking, right? Like you're spending all this money to come to Canada to get training and then everybody's saying, take this, do this, do this, do this. My friends did this, you did this, and they did this, and I saw this, and right? And so, yeah. And you don't know, nobody, and the thing with PBC is like they're very closed off. They don't share. It sucks. So we kind of figured it out over the years and being just dedicated. And for those of you who've been part of the journey with us, you've helped us grow, we help you grow. We've all worked together. And that has allowed us to figure it out. But that's like that's the honest, raw truth. And I'm glad that makes sense. And when it comes to studying extra in MCQ, there's more clinical topics in MCQ. There's more management. It goes a step further. It does go a step further than EE. But 100% in EE, there's also case-based questions. There are in both. So when this is just some examples of what we've done at SolRx, where we've taken material from CPS and digested it and delivered it in the way you need it. And here's the thing, CPS is important. There's no denying that. And that's why I will take my stuff from CPS and share it with you where it's needed. Like drug tables. You do not need to know every side effect of every drug and have these crazy drug tables. And with like, everybody I've talked to over the years, I've come to a conclusion that the drug tables in CPS are enough. So we've dissected that and provided it to you. Where there's more information required, where there's changes required. So we put it all together because it's not just CPS. Also, now with pharmacists prescribing, minor ailments prescribing, your PEBC exam follows trends. Minor ailments is important. So I know Canadian Pharmacists Association has wonderful sources on like tick bites and what patients need to know and the angle to pull out the tick, wink, wink, which I've seen appear, wink, wink, on the exam. So we provide all of that with you and we follow the trends, which is what's tested. The last thing you need to do is go online and go to 1,000 sources, right? So this is just an example, okay? So are you guys down? I was thinking we can do a fun cardio summary. Do you guys have a sheet of paper? I thought, why not? For those of you who know me, I love summaries. And I was seeing on the WhatsApp group, you guys had questions about cardio and then the antiplatelets. So what do you guys think? Yeah? Okay, a little bit of excitement would be nice. A little bit of enthusiasm would be good. Yeah? Okay, I need a little bit more than that. Come on. Let's do it. Okay, but I need you, let's get a blank sheet of paper. Do you guys have a blank sheet of paper? I'm like, oh my gosh, guys, only 2 of you? Okay, multiply. I need more excitement. Okay, perfect. So, woohoo. Okay, perfect. Let's do it now. Okay, perfect. So I want to do one main one. Yay. Okay, awesome. The main one I want to do is my favorite, which is acute coronary syndrome. So I'm not going to go into all the crazy details, but just at a high level, because a lot of students get acute coronary syndrome confused. That and then heart failure and so many different things, right? So what is acute coronary syndrome? And like, I know these words are super fancy and super annoying. I know. Acute coronary syndrome. Acute, meaning it's just happened. Coronary means it's involving the heart, coronary. Syndrome, meaning condition. And there's different types of acute coronary syndromes, okay? The main one, the scariest one is STEMI. That's the absolute scariest one. In STEMI, patients have a full blockage in the coronary artery, okay? They have a full blockage. And what happens when there's a full blockage? That's life-threatening, right? The myocardium is dying, right? Then the heart's not able to pump, okay? And this one is super time sensitive. We got to treat it ASAP. And then we also have another type of acute coronary syndrome. It's called NSTEMI or unstable angina. And the reason why NSTEMI and unstable angina are lumped together is because their clinical presentation is very, very similar, and it's hard to differentiate between the two. And there are a few differences, but for your exam, we lump them together. And then other than that, we have something called stable angina. So stable angina, I'm going to put a squiggly line from ACS. Stable angina is more chronic. So it's not really an acute coronary syndrome, but it can definitely lead to a full-on heart attack. And it is a risk factor. So I still put it there. Now, let's say you have a patient. The patient comes to the pharmacy and they're having chest tightness. You think they're having symptoms of a heart attack, you know. And what's interesting is patients who are elderly or patients who have diabetes, they may have atypical presentation, so irregular presentation. And I'm going to go through it a little bit fast today, but so bear with me. But some patients will have heartburn as a heart attack. So they'll have heartburn where nothing will work and it's getting worse and they're getting up at night. And they'll think it's just heartburn where it's a heart attack. So people can have atypical symptoms. So when in doubt, just go for it and treat. So the first thing we do for STEMI and unstable angina, if we're suspecting anything, we give aspirin immediately. And so they would chew 2 aspirins. And they would chew. Chew is key. Let's say if they have nitroglycerin sublingual, great. If not, we still have to call 911. Let's say we get to the hospital. They may try nitroglycerin spray, sublingual, and if it doesn't help, they'll do IV if the sublingual is ineffective. Nitroglycerin does not have mortality benefits. Nitroglycerin does not have mortality benefit. It is just there for symptoms. Nitroglycerin is only good for symptoms. So if someone's having chest tightness, this will help them maybe feel a little bit better, dilates the arteries. Okay, so that's something to keep in mind. It does not have benefit. Okay, now there's several different things that we will do for the patient. Typically, once they are admitted to hospital, we will give them heparin. Okay, so I will just write it here. We typically prefer low molecular weight heparin. And this is for the duration of the hospital stay. For the duration of the hospital stay to prevent clotting, deep vein thrombosis, because when someone has a heart attack or somebody's hospitalized, guess what's going to happen? They're going to be immobile and will be at risk of clots. And so we usually do this for the duration of the hospital stay. Now, how do we know if the patient has STEMI or NSTEMI, or what do we do? So I'm going to put a line down the middle, just a little line here. Let me change the color here. Don't worry, this is not going to be too long, but this is my absolute favorite topic. Okay, let's switch to blue. So when someone has STEMI, they have a full blockage. So this is like crazy time sensitive. Okay, full blockage. And then NSTEMI, unstable angina, is partial blockage. So going back to STEMI, because in STEMI you have a full blockage, we want to break that clot. So we want to do fibrinolysis. So we have to say, do we have time for fibrinolysis, also known as alteplase? And let me explain that a little bit. Fibrinolysis medications like alteplase dissolve the clot. They dissolve the clot. So imagine how strong it is. It's not like aspirin. You tell me, does aspirin dissolve a clot? What does aspirin do? Why can't we use aspirin to cure the STEMI? And if you don't know, say, Farah, I don't know, and that's okay too. Any thoughts? And if you don't know, say don't know. So aspirin, when somebody has a heart attack and they chew to aspirin, it prevents the clot from getting bigger. It doesn't dissolve the clot. Aspirin prevents the exact, yeah. But fibrinolysis, alteplase dissolves the clot. So imagine how strong it is. And because it is so strong, we have to be very, very, very careful of how we use it. Because if something is that strong, what can happen? Brain bleed can happen. So it can actually cause significant side effects and issues. So we have to say, do we have time for fibrinolysis? Do they need to get to a specialty hospital for fibrinolysis? So typically, we will do fibrinolysis. And of course, there's many different factors. And right now, we're just having a general understanding. It has to be done within 6 hours of symptoms. Symptoms onset. If it's beyond that point, risk versus benefit. And let's say it's been 10 hours, and it's not 6 hours of getting to the hospital, 6 hours from symptom onset. And if it's too late, we'll consider like invasive therapy. So they may do a stent or balloon or whatever, which is beyond our exam. In NSTEMI or partial blockage, because it's not a full blockage, we don't really do fibrinolysis. We may do it if it's extremely bad, but usually we don't do fibrinolysis. We may do invasive therapy. So I'll write that. And that's beyond our exam. So invasive is like a stent or like a balloon. So invasive therapy. And then going to STEMI, I'm just going to write ALT as alternative is invasive therapy. Okay. So now what? Now we do the drugs with mortality benefit. So what does that mean? The medications that prevent another heart attack from occurring. That's called a mortality benefit medication. And on your exam, you have to know which drugs have mortality benefits and which ones are just good for symptoms. And in STEMI and NSTEMI, there actually tends to be a big overlap. So watch this. I'm going to write in green the mortality benefit drugs the patient should do in hospital and then continue on when they get home. So we'll do that in green. And I'll write it here, ACE. And sometimes they'll start it here. So I'll put a star here, sometimes started here. But that doesn't matter for your exam. Sometimes they'll start it later. At the end of the day, as long as it's once a patient is getting stabilized, we start it. So ACE inhibitor. If we can't do ACE, we'll do ARB like always. So or ARB. We will also do a beta blocker plus high dose potent statin. We will also do ASA, so aspirin lifelong, swallow 1 daily. What about the second antiplatelet? Because after somebody has a cardiac event, we're going to do 2 antiplatelets. Aspirin is lifelong, but we're going to use a second one temporarily. So what is that going to be? And I'm going to tell you dual for a year exactly. And so the second antiplatelet is a P2Y12 inhibitor. Very good. P2Y12 inhibitor. And you have two options. Very good. So I'll put it in brackets. You have clopidogrel or ticagrelor. And this is the main tip. If you remember this, you're fine generally. So usually we use clopidogrel if they have STEMI and they got fibrinolysis. We will do ticagrelor if they have NSTEMI or unstable angina. Or if they have STEMI plus invasive therapy. Meaning they didn't qualify for fibrinolysis. Maybe it was too much time that passed. Take a minute to read this and then let me know if this makes sense. And the green is to continue at home. Okay, so this green is to continue at home. And then to answer the question online, invasive therapy, so balloon or to needle time is 90 minutes of arrival of hospital. What I just wrote, take a second, does it make sense? Because then I want to briefly talk about stable angina. Let me know. I'm gonna put a dotted line here. Guys, does it make sense? Or maybe you're still writing, so I'll wait. Okay, why don't we give clopidogrel in the case of invasive therapy? That's what the guidelines say. And that's what CPS also says. So both guidelines and CPS both say that. Okay. Now, stable angina, we don't, and yes, high dose statins regardless of lipid profile. So lipid profile doesn't matter. If they've had a heart attack, automatically high dose, either atorvastatin or rosuvastatin. And then when it comes to stable angina, because it's a chronic condition, we're just giving them the medications at home. So the mortality benefit drugs are very similar in stable angina to STEMI and NSTEMI. We're doing ACE or ARB, ideally ACE, plus beta blocker, plus potent statin, so high dose. And then these patients are usually, there is some conflicting evidence, which we won't talk about today, but we may do ASA lifelong. And we'll use nitroglycerin as needed, either the patch or the spray. You remember? Oh, good. But guys, this is literally heart attack summary. What drugs to use? And then, of course, we take it one step further and yada, yada, yada. But if you wonder and you remember, yeah, but this is the baseline, and then we take it a step further. That's all you need to know is in cardiology, if you understand which drug to use in what condition, that's cardiology. That's it. That's it. And in which condition to use antiplatelets versus anticoagulants. Like in heart attacks, we don't use anticoagulants, we use antiplatelets. We use anticoagulants in AFib. And in heart failure, we don't use antiplatelets or anticoagulants at all. But these are the key things to take away and then apply them to situations. I want to do, so let me know when you're done writing, because now I want to do an insulin practice question. And then we're going to talk a little bit more about the PBCs. I just get excited and I thought might as well share some key things to help everybody. So let me know, can I move on to the next one? I will wait. Woo! Okay, hope you guys are excited. Okay. I know calculations are not always fun, but that's okay. In MCQ, it goes a step further. They will ask you more cases. They will ask you, the patient may have a heart attack and heart failure. And then they'll say, which drug do we discontinue? Which one do we add? Okay. But it could both be an EE. This could be an EE and MCQ. Okay, now let's do this case-based question. So take a look. Emily is a 22-year-old female recently diagnosed with type 1 diabetes after presenting with symptoms of polyuria, dyspnea, unintended weight loss. Lab results reveal hyperglycemia, fasting is 15, and a very high A1C. We want to start the patient on insulin, full insulin. So now we're doing, you can see Tresiba, which is insulin degludec, and then Novorapid, which is insulin aspart. So how do we calculate this? How do we calculate the dose for your exam? So I will teach you. Oh, hi. Yes. This is I'm with SolRx. No, don't be sorry at all. Okay. So you have to know this conversion on your exam. You have to know. So do you guys make sure you have your pen and paper ready, because I want you to write this down. When we're starting somebody on insulin, combo insulin, like long-acting and short-acting, and there's different strategies, but this is just for today. You need to know and calculate the patient's TDI. TDI is total daily insulin. How do we calculate the total daily insulin? Total daily insulin is you take the patient's weight in kilos, you multiply. Very good. How many kg is 130 pounds? How many kg? So 130 pounds divided by 2.2 will give you the answer. So 59. Very good. 59.9. So what we're going to do, very good, we're going to take the total daily insulin and we're going to plug it in with the kilograms, the weight. So we're going to do TDI is equal to 0.5 times 59.1. So what is TDI? What's our total daily insulin? It is, anybody? Very good. Very good. 29.54, 29.55. Perfect. Now, that's how much insulin our patient Emily needs in a day. How do we break it up into basal and bolus insulin? So we'll start with basal. So I'm going to put 2 arrows. Let me change the color here as well, because I learn with when I write it with color. And if you don't understand, make sure you stop me, because everybody has to understand this. So basal insulin, and remember, degludec is basal. Aspart is bolus. So basal insulin is you are taking 40% of total daily insulin. Bolus, which is your short rapid acting, is 60% of total daily insulin. So how do we calculate this? You take 0.4, which is 40%, times 29.55, and here it's 0.6 times 29.55. So what would be the answer? Your basal would be 11.8. Very good. And then your other one, your bolus would be units. So basal insulin we do once a day, usually before bed, but basal is typically once a day. But how does bolus work? Bolus is usually 3 times a day, right? Usually before meals, with each meal. So you have to take this 17.7 and you have to divide it. Does that make sense? We have to divide it by 3. So let me write it. Divide 3 based on meals. So the patient would do, so the answer for bolus is 5.9 units with each meal. Does this make sense? And then I'm going to answer your questions now that I'm done writing. Does that make sense? There's many different insulin conversion stuff you have to know, but this is one of the very important ones. Can I explain how total daily insulin is 0.5 units per kilos? That's based on CPS and Diabetes Canada. That's how they use for that's what they use for calculation. So that's something you have to memorize, 0.5 units per kg, and then 40% basal, 60% bolus, and then you take your bolus and you divide it by 3. Does this make sense? Take a minute and read it. take a minute and read it, okay? Oh, thank you for the kind words. Thank you. To answer your question, which is better for hypoglycemia risk? 3 smaller insulin doses or 2 higher doses? It's better to have smaller doses than very high ones. Remember, hypoglycemia is worse than hyperglycemia. Okay? You have to be careful and you have to know that. Oh, dear students, thank you. I'm so happy. But guys, does this make sense? Like now you know 0.5 units per kg and then 60/40. You got it. That's it. Yay. Oh, thank you, dear students. Good. Okay, that's awesome. I'm glad you know that because that is like so important. Good. Yes, PK calculations, yes, they do come up in MCQ as well. Yes. And we talked about this question. Do you need to use multiple clinical sources? You don't. And that was my honest truth. And this stuff is not written anywhere, right? This is just me honestly sharing. Guidelines are the ultimate source, but for your exam, CPS is key, but reading CPS is not enough. You need it to be dissected, evaluated, and taught in a way for the PBC, which we talked about. And then my favorite question, what is high priority? What is low priority? What is medium priority? There's no priority. And that's what makes it really hard. Okay? And so this is how I see, okay? Like this is how I think about it. So if you have a topic like HIV, are you really going to sit 8 hours, memorize all the drugs for like maybe 1 or 2 questions, and maybe those questions are pre-test? HIV is not as entry to practice for an average pharmacist. It's more specialty. Well, what should you know about HIV? You should know opportunistic infections. So people with HIV have a lower immunity, so they're more at risk of getting that P. geovrici, whatever that infecting pathogen, P. geovrici, and so you give them sulfamethoxazole trimethoprim as like preventative, right? So you should know opportunistic infections for HIV and which antibiotic is used for prevention. But if I tell you to spend 8 hours and learn each HIV drug, is that practical? Is it worth it? Probably not. Same with TB. So it's like you have to weigh, right? And in the ideal world, we can memorize everything and know everything, but it's about studying smart and saying, okay, guys, in class, I'm going to talk to you about how to understand this information. And then you're going to go home and review it and understand it and memorize it. And then we're going to do practice. You know what I mean? And oh, thank you, Lef and Wat. That is a very kind comment. Thank you so much. Thank you. Is it true that there's another scheduled MCQ in OSCE in February? So yes, now it has changed. And you do not have to take MCQ and OSCE together. You can take them separately. Yeah. And so one of our colleagues, you didn't get opportunistic infections. You had a complete case of HIV. Yeah. And depending on the question, maybe it was pre-test, maybe it wasn't, but it depends on how it was asked. I see some people get HIV, some people don't. Is it likely pre-test? Probably, if it's a complex question. And it also depends on what they're trying to ask you as well. So do you know what I mean? Does that make sense of the approach? And again, we provide you with HIV, and by all means, you're given the full material, but it's about trying to figure out which topics to study smart. and what to focus the time on. But again, you never know. So it's all about trying. And it's like a juggle. You just do your best, like an educated guest kind of thing, right? Can you take both at the same time? You can take both at the same time. You don't have to do one and then the other. You can do both at the same time. Absolutely. Okay. So my dear students, I'm going to pass it on to Dr. Parag and Dr. Parmeet, who want to shed some light on management, and then we'll talk a little bit more. This was super fun. I'm still here, but I'm going to pass it on to my phenomenal colleagues, Dr. Parag and Dr. Parmeet. So take it away.
Thank you so much, Farah. So if you can just go to the next slide. Yeah, just stay there for a bit. Okay, so thanks again, Farah. And I just wanted to say once again, thank you for everyone joining us. This kind of energy is what drives this whole thing, right? And I speak for Farah, Aarav, Parmeet, myself, and the rest of the faculty at SolRx when we say that our fundamental reason for being here and doing this is genuinely to help candidates to achieve their professional goals, and in this case, namely to help clear the PEBC exam. Okay, so Farah, of course, did an excellent job in giving you an idea of the overview of the exam and how to prepare for the therapeutics portion specifically. She also did touch upon certain things already for the management, but I will highlight and reiterate and repeat certain key ideas so that you have a comprehensive idea of how best to prepare for the whole exam. Okay. So I will take a few minutes to give you a proper mindset, and that's really important. That's probably majority of this whole journey, this whole thing, having the right mindset. Okay. I'm also going to give an idea of how best to prepare specifically, more importantly, think about management and where we break down management and calculation questions for the exam. We already discussed this. The exam is categorized into two main portions, therapeutic management, and in management, we can kind of further separate into calculations, okay? And the way we prepare and think about the management and calculation questions is very different than therapeutics. Farah? Okay, so you can stay there for a bit. Actually, you can go back 1 second. Farah, thanks. Understanding management for the PEBC exam, it's not always black and white, okay? So let's talk about that for a bit. Okay, let's talk about the non-therapeutic clinical portion of the exam. I want to, right from the beginning, explain a key fundamental difference. It is not black and white. It's gray, okay? There is a middle. There is this nuanced kind of way of dealing with situations. What does that mean? It means that we have to look and think and use our concepts, our knowledge, our understanding, and experience when dealing with management situations, okay? Which can be different each time. It all depends, okay? A perfect example of this is professional ethics. Many of you have heard about this. Some of you are already aware of it. It's a key competency that makes up a lot of these management questions. There is no algorithm. There is no formula that, unfortunately, I can give you to come up with a solution. We have to think deeply and really understand what is being asked, where is the patient, what are the other stakeholders, for example, right? I know this sounds a little bit like you're in the dark, but there is a light. There are thought processes and strategies, and more importantly, different cases and scenarios that we can use to illustrate important concepts. This is done under the guidance and oversight of an experienced instructor. Okay, thank you, Farah. Keep going now. So management questions on the PEBC aren't about picking a textbook answer, right? You can argue that perhaps therapeutics is a bit more clear cut. There's an answer, you can get it. There's an algorithm. However, in management is a different beast, right? They often test your ability to interpret real life pharmacy scenarios. This is really important, okay? We have to apply our judgment in these gray areas, not just follow rules. As much as we would like that, that's just not the way life works. That's not the way the profession of pharmacy works. And definitely, that's not necessarily how the exam works, okay? We have to think like someone running a pharmacy. We have to think like someone that's managing a pharmacy and managing people, managing workflow, and of course, dealing with patients, okay? Farah? So these questions reflect how things work in practice, not just how they should work on paper. Okay? So what is the point of the PEBC exam? I know that sounds like a really redundant and silly question, but it is to make sure that the licensing bodies and regulatory organizations know with confidence that you are capable of practicing to the full extent of a Canadian pharmacist, serving the public interest. Therefore, we are very much interested in real life scenarios, okay? And that's what you're going to be seeing. These questions are going to reflect this. All right. Exposure to Canadian pharmacy practice, even indirectly through your prep course, can make a huge difference. Unfortunately, not all of us have the opportunity to work in a pharmacy, okay, to get real life experience, which can be a difference maker. However, if you pick the right prep course, you can receive this experience indirectly. Next. Okay, so what to look for based on this idea of how to get this experience, how to get this idea, just because unfortunately, and fortunately, actually, you can think of it, we're not going to get straightforward questions, okay? That's not the point of the regulatory bodies, the licensing bodies, and of course the PBCs, okay? So what to look for in a prep course to get this experience, especially for management? Let's talk about that a bit. So far, yeah, thanks. So the PB exam doesn't just test clinical knowledge, right? The management section oftentimes is what is most challenging for a lot of candidates because it is very different, right? We understand and empathize how coming from abroad or a different jurisdiction or different country, the role and the industry and the profession of pharmacy is very different versus in Canada, okay? So what are some things to look for when choosing a prep course to get this experience? Instructors who actively practice in Canada. I know Farah already talked about this, but real world pharmacy experience matters, not just teaching from slides. Everyone here is a practicing pharmacist, period. Everyone. We are working. I'm working tomorrow. I'm wearing my lab coat that's still wash. Okay. So that matters. Faculty with leadership or ownership roles. This is key as well because we have intimate experience and knowledge on how to deal with a team, how to deal with roles, conflict resolutions, ethical matters, even the business and financial aspect of a pharmacy. Okay, so if we have this experience, we can teach it. And then Canadian trained educators, right? Most of us have actual training in Canada. We've done school in Canada. We've all done the licensing exams. So we know exactly what we're talking about. We can say we've been there confidently, right? We have, and we understand what it takes. Okay. So a tip, a strong course doesn't just teach you what management is. It shows you how to think like a pharmacist. Okay. A thought process. That is what we want to convey. Okay. Now, there's a word that strikes fear in a lot of people's hearts, and that's calculations. And that is a part of management, and it is a weak spot for certain people and oftentimes underestimated. So, how do we tackle calculations, right? It's more than just a formula sheet. You can't just memorize a formula. It's about knowing when and how to apply the formulas. It's very important. Okay, this is what they're gonna ask for in practice and the exam. They want to know when to use, how to use certain things when it comes to calculations. So therefore, when you're looking for a prep course or a program, you want to have a dedicated calculation expert, someone that can break down these things, explain step by step, and simplify complex problems and work with you, right? It's math in the end, and math has to be taught a certain way. And this leads me to probably the most important thing about real life pharmacy scenarios, okay? Pharmacokinetics, bolus dosing, IV drugs, compounding, alligation, so on and so forth, right? It goes beyond the theory. It shows how calculations show up in real practice. I'll give you a perfect example. Let's say, for example, you have an IV medication, okay? And you are tasked to figure out how to calculate the serum levels of this drug in our blood, okay? So you have the dose, you have the interval, and you figure it out. Now, what if they ask, or we want to figure out or address, how can we change the serum levels? Do we change the dose? Do we increase it? Do we decrease it? Or do we change the intervals? Understanding the fundamentals of calculations will allow you to apply this knowledge in real life and an exam situation. All right. So that just gives you a general idea of how to kind of approach and think about management questions, where a prep course with experienced instructors is crucial. So I hope this gives you a good idea. I'm actually now going to pass it on to Parmeet to wrap up this session.
You're muted.
Parmeet, we can't hear you. Sorry.
Can you hear me now?
Yes, great.
A little bit of issue happening there. So sorry.
No worries.
But as I was saying, thank you, Farah and Parag, for that amazing session on management, a little bit of how to tackle questions and, what SolRx or what you should be looking for in a prep course, kind of alluding to what we have to offer as well. And Dr. Farah's amazing summary on cardio. So if you guys enjoyed what you saw, SolRx does have a prep course focused on MCQ, led by, all these instructors that you have seen. So Parag, Farah, Aarav, myself, and Dr. Hye-Yeong as well. And the prep course is available for registration as we speak. The course itself will start around July 15th, and then it will be running for 14 weeks. Within these 14 weeks, there will be 2 classes per week on Tuesdays as well as Thursdays, running from 9:30 a.m. to 2:30 p.m., so about 5 hours per class. And like we said before, equal attention will be spent on both management and therapeutics. And of course, we're going to give you a lot of practice for calculations. Enrollment is open, so the content is available as soon as you register. So if you want to get ahead of the game and start reading the books, practicing the questions, everything is available on our learning platform. If you guys have any questions for either one of us, whether it's about the course or the content or the exams, now's the best time to ask, and we're going to stick around for a bit and answer any questions you may have. So we'll open up the floor to questions. Please use the chat, start typing. If you guys have any questions, we will answer them. So I see Sajan. What about OSCE? I do also see a question about cost as well. I'm going to get to that as well. OSCE is also taught by SolRx. We have a separate session planned for OSCE, and that one is going to be on, let me just open my calendar. I haven't actually promoted it yet, marketed it, but it's going to be on June 21st. So not this Saturday, but the following Saturday, we are going to be doing an OSCE open house hosted by the OSCE faculty. I'm going to be starting to post registration forms online in about a couple of days, so keep an eye out on our social media. And you can also register for that introductory open house to see what we have to offer for OSCEs. Now, when it comes to the cost of the course cost is about $15.49. And of course, tax is applicable depending on where you live. And in terms of OSCEs, we are going to discuss that during that open house. So I see a question, what is the pass rate for MCQ? So MCQ pass rate and even OSCE pass rate always fluctuates depending on the cohort. Like we said before, a lot of it depends on the student's ability to spend the time to practice what we have taught them. The pass rates have always been exceptional for SolRx, which is why we are known for what we do, especially for OSCEs as well as MCQ. So I would say it's a very good rate. And, it really depends on how much time and effort you can put into the course. Rose asks, how detrimental is it to attend on the days that the course is offered? Does it make sense to sign up? So as any course or any class, whether you're in school or taking a preparatory course, attending the actual class obviously does help. It has a lot of value because you learn a lot when you are actually physically attending a class, whether it's live or in person. Of course, this is offered live, it's offered online, but I would say it's fairly important. But if something does ever come up, just know that the classes are recorded, so you will be able to view them at your own leisure, at your own time. And even if you learn something in class which is not very clear cut, you can always go back and look at the recording. Adrian, you can reach out to me or Aarav individually, and we can talk about installments. But that definitely could be an option if you are interested. MCQ classes are not physical, they are only online. They're put on our Zoom platform, so similar to what you have today. OSCE classes, however, availability is there for in-person and online, and of course, depending on how many seats we have remaining. Like I said, Marlene, the cost of the course is $1549 plus applicable taxes. Shandana, I see that you're asking about an EE course. At this current moment in time, we don't have an EE course available to purchase. However, we are currently working on it, and it will be available hopefully sometime in 2026.
There's a question about working full time and the ability to study and prepare while working. So I have seen, and this is what's interesting, I've seen people study full time, 8 hours a day, 7 days a week, and not be successful. I've seen people study 8 hours a day, 7 days a week, and be successful. I've seen people study while working full time, studying after work 4 hours a night and pass, and those who do the same and not pass. So at the end of the day, it comes to each individual, their dedication and their ability to follow and keep up. And if they can't keep up, being honest with themselves and taking the time. So 100%, I've seen it to be possible. It is, as long as you dedicate the time and follow the guidance provided. Yeah.
Maninder will be releasing the recording on our social media, so it's going to be posted on YouTube tomorrow. You can access it through that way, and I'll also make a post on Instagram as well, just letting everyone know that it's been posted, as well as the WhatsApp group.
Does working in a pharmacy help to clear? So working in a pharmacy is helpful. It's not mandatory because if you take proper training, you're able to learn about the pharmacy practice and understand. What I do recommend, if you are in Canada, I would just go into pharmacies and observe and walk around the aisles. Like I remember when I was a student, I would just go into aisles and read products. But I don't think you need to force yourself to go out of your way to gain that experience. Okay. And a lot of times when you're starting out in a community pharmacy or you're volunteering, you may not get that full exposure anyways. They may make you do very administrative tasks where you're not getting that full exposure. So you don't need it. I've seen people pass with a significant number of people pass without the experience, but they have proper training and follow through with that.
So Kunal, that's a good question. Do you recommend taking both exams together one at a time? At the end of the day, it really depends on how much time you have to allocate towards both exams. Realistically speaking, you do need about 40-ish hours to study for MCQ and about 20 to 30 hours for OSCE. I would even argue at the higher end for OSCE. So usually students, if they do decide to take them together, you have our full support. We try to give you some insights and support you through your journey. But at the end of the day, if you are, busy with other commitments, whether that be family, work, then usually we would recommend one at a time. That would be the best bet. Yes, Adrian, we do have tons of quizzes available for every single topic that we have in our course, as well as our extensive mock exam. Within our course, you actually get access to two types of mocks. First one will be a midterm mock exam, which is going to focus purely on management and calculations, as we know that is a big concern for many people. And then, of course, at the end of the course, you get access to the complete mock exam, which gives you access to therapeutics, management, calculation in a mock setting. But along with that, you have tons of quiz questions, and the question bank is quite vast. So you'll have pretty much access to a lot of information. Any other questions, anyone? If not, then we will approximately over 5,000, Ritu.
But just be careful because it's not necessarily about the number of questions you do. So I've seen people do thousands of questions and not be successful. And I've seen people do one quiz a topic and be successful. So be very careful when studying. We tend to say, okay, if we review this much material, we're this much more likely to pass, but it's not necessarily the case. You can study less and be successful if you're doing it the right way. And one big problem I see is that if people haven't done an entire question bank, or if their friends did 2,000 more questions than they did, their confidence will go down, and then that will go into their exam and in their mind, and that will affect their ability to pass. So never feel that the amount of questions you do or the amount of revisions you do 100% correlates with your chances of passing, because this exam is way more than that. So just be mindful of that. It is important, but I just want you to be mindful of that because I see that mistake all the time. You're welcome.
All right, any other questions? And, if you do think of questions while you're sleeping tonight, feel free to send us a message on the WhatsApp group, or even email us at info@solrx.ca, and we'll be more than happy to get back to you. We also have a contact us page on our website. And I do encourage you guys to go through our, social media, our website, and see what we have to offer. Even on social media, we try to post some tips and tricks for OSCEs, and we will continue posting tips for OSCEs just to kind of get everyone else engaged in a social setting. So that being said, I guess we'll kind of wrap up the session. Thank you, everyone, once again, for taking the time out and attending today's session. Just a quick reminder, we are going to be having our OSCE open house on June 21st, which is going to be not this Saturday, but the following Saturday. And I will be posting information about that on our social media. Right now, we do have the session that we promoted this group on. You can always discuss amongst the peers on that group. And once you register with the course, there will be a specific course-only WhatsApp group where you get access to mentors and the faculty, of course, if you have any questions or if you want to discuss questions with your peers, which we highly encourage. All right. So we'll go ahead and wrap up the session tonight. Thank you again, Parag, Dr. Farah, Dr. Aarav as well. And I look forward to seeing you guys hopefully in the near future. And we'll go from there. Thank you, everyone, and have a great night.
So much.
Thanks. Good night, guys.
Bye.